Hello and welcome to Nutrition Unfiltered, a podcast where science meets sass. I am Christy Maloney, registered dietitian and eating disorder specialist. This is a place where we talk nutrition, ask the hard questions, and have some fun along the way. I'm so glad you're here. Hello again and welcome back to Nutrition Unfiltered. Today I have the honor of having my good friend, my employee, all-around wonderful human being, Allie Richardson with me. So Allie, when we dive in, first of all, just tell us a little bit about yourself and a little bit about your background.
Well, first of all, thank you. I just love and adore you. Yes. So hello, everyone. I'm Allie. So a little background on me from my career standpoint. I went to Iowa State University for my undergrad. Graduated there and then did my internship through Keith and Associates, distance dietetic internship. Long name. But so I did clinical rotations in Oklahoma. A fun fact, lived in a hospital during my clinicals because housing was a nightmare. I don't know. Did I ever tell you that?
I had no idea. You lived in the hospital.
Yes.
That's commitment.
Oh my gosh. Long story short, my housing situation got so messed up because they had to switch hospitals that I was in. And all of a sudden I was in this super rural area that didn't have short-term apartment leases or anything, or I didn't know anyone there. So they were like, you can just live in one of the hospital rooms. Oh my gosh, it was crazy.
I've never heard of that before. I feel like I've heard of most things and I've never heard of that. So that is a fun fact.
Fun fact. Yes. It was crazy. And then they wouldn't let me stay over the weekends. Rightly so. I had to drive home. I have to drive 6 hours home. It was crazy. Back to Iowa.
Wow.
Sorry. I'm wow. Welcome to the podcast. Here's a fun fact.
Welcome to the podcast. Glad you don't live in a hospital anymore.
Seriously. But then I went to Charlotte for the other half, and that is where I met you. Mm-hmm. Just loved your style, loved your practice. That's when I fell in love with eating disorders. And so from there, finished up my internship in Charlotte. Then I started working at a hospital that you worked at.
That's
to
right.
get some clinical experience. Was so ready to get out of that. And messaged you and was like, hey, are you looking to expand your new practice? And now here we are, almost 4 years later.
And I will tell anybody, Allie is the reason I have a group practice, because I never really kind of saw that. And then Allie came on and here we are now, 6 dietitians in. So it's been great. It's been great.
Forever grateful. It's so fun. I love working with you.
So Allie in our practice is our ARFID specialist. So today's podcast, it hopefully is a little bit of education for professionals on what is ARFID. I feel like it's one of those that a lot of people just don't understand, or if they have a basic understanding, they feel like it's very scary to treat. And so Allie has really taken on, treating this particular population and has a lot of good education, training, insights on just working with someone with ARFID. So first and foremost, Allie, give us a little overview of what is ARFID? What exactly is that?
Yes. So ARFID is Avoidant Restrictive Food Intake Disorder. I always get my letters mixed up, but yes, that's what it stands for. And so really any age range can have this happen to them. Typically will start in toddlerhood and then can go into adulthood. A lot of times this gets labeled as quote unquote picky eating, but it's more complex than that. And it tends to kind of slip through the cracks a lot more in younger kids than kind of what's realized. So catching it sooner rather than later will just only help your clients, your child later on in life. So that's just kind of quick background of it.
Perfect. So if you're looking to catch it early, right? What exactly would you be looking for? How would you know the ARFID is sort of presenting itself?
Yeah. So if we think about toddlers, just in general, okay, every toddler is going to go through a quote unquote picky eating stage. During that stage, if you keep introducing foods like broccoli, strawberries, blueberries, things that squirt, things that have different textures, right? Yes, toddler's not going to love those, but eventually they're going to see you eating it. They will start to eat it, learn how to deal with those different tastes and textures. If your toddler or child is really struggling and is that tastes icky on my mouth, that's a really intense flavor for me, then that's when I encourage if they're seeing a therapist or food therapist or parent, to kind of encourage the questions of like, well, tell me what that tastes like. Does that taste sour? Does it taste or does it feel crunchy and soft at the same time? Do you not like the two textures together? And really kind of getting on their level of understanding what that feels like on their mouth. Because there are things called super tasters. And so they taste flavors a lot more intensely than just like your average person or average kid. So when something tastes sweet, it can taste really, really sweet. Or if something tastes bitter, it'll taste really, really bitter. So broccoli is a bitter vegetable. I'm just using this one because it's a very common ARFID, like no food.
Sure.
So that is one, like it tastes really bitter. If it's not cooked with enough fat, it doesn't help coat the tongue. And so then it's all around, like it's crunchy, part of it's soft, part of it is like leafy and flakes off, and it's all these different textures in their mouth, but it's also a couple different flavors. And they're like, yeah, I can't do this. Spit it out. They tend to spit out a lot of food. And then with that, then they go to their basics. A lot of times that's chicken nuggets, potato of some sort, so French fries, mashed potatoes or roasted potato, peeled apples, biscuits, plain buttered noodles, like very just like plain foods that are safe, that are consistent. That's why when you look at like, will they eat a fruit? Probably not, because fruits are variable, whereas a Ritz cracker is the same every single time. So that's just kind of like a few little points just to kind of look out like, is this happening a lot with my kid? And are they afraid to venture out? Kind of thing.
Right. And when you think about sensory overload and the way you describe the broccoli, there might be 2 or 3 textures. There might be very intense, bitter flavor. So for somebody, and especially, people that maybe are on the spectrum, that kind of thing, have ADHD or neurodivergent, that have sensory, I won't call them issues, but just really high sensory stimulation. That is one of those things that we can really see. What do you think about like that population and, how that plays into just kind of overall the sensory stimulation? And, I guess what I'm trying to ask is like, if a kid is very like auditory stimulated, right? Maybe they can't deal with loud noises or really like bright lights or that kind of thing. How often do you see this playing into that population?
It's very, very common. If you're somewhere on the spectrum, very common that you're going to have some sort of sensory overload with food in some way, shape, or form, or an intense fear of it in some way, shape, or form. So like, again, I'm just going to keep using broccoli because it is the one food that every one of my ARFID clients is like, absolutely not. If you think about it, especially if someone's very sensitive to loud sounds, and if you have a crunchy piece of broccoli, holy cow, to them, that is like so intense and so loud. So really, when you're thinking about exposing them to that food, which I'll get into more of a second, you almost need to have that like broccoli, like overcooked, so soft, so the crunch won't be intense for them. But in this population, I noticed you have to take it very, very slow. And that can be really tough for some parents and other professionals too, because it has to be such a slow process. Because their brains just work a little different, and that's totally okay. But it's just a much slower process because change for them can only be small doses, and they have to know what to expect. So when things kind of come up unexpectedly, it makes them nervous, can have outbursts. They revolve on their stemming to kind of get them back. And it can just be a very delicate balance. You just have to learn how they process and deal with things, which can take a couple months when you first start with a client to understand how do they process things. Is this something I can lay on and push, or do I need to back off them more and let them sit with this for a little bit? Just as with any client, you just have to be a little bit more delicate when you have a client that's on the spectrum.
And I think that's a really great point. If you, our beloved broccoli, if you have that, if someone is eating raw broccoli, there is a crunch, there is a texture, there is a smell, there is a taste. That's 4 different senses that we have engaged. And so kind of to your point, it's like, okay, so how do we reduce as many senses as possible being stimulated, right? Like if we're working on texture, is there anything we can do to help, like you said, the auditory? Is there anything we can do to help with even the smell of cooked broccoli? What can we do to sort of alleviate those other things so it's not complete sensory overload?
Exactly.
I'd never thought about it that way. So thank you for enlightening me on that.
Hey, you're welcome. This is my jam. So I'm here for it.
So I love it. So if we're thinking about, a dietitian, because this particular episode is geared toward ARFID and the professional treatment of ARFID. So when a client comes in, how would they assess for ARFID, right? So parents might bring in a kid for picky eating. How do we know if it's just we haven't tried a lot of foods versus it's this type of eating disorder?
Yeah, so I use the DSM-5 criteria a lot just as a base. That doesn't mean that, as we know with any eating disorder, it doesn't mean it covers every single person every single time, but I use it as a base. So a lot of times I will frame questions around that criteria. Are they low body weight? Are they having failure to thrive? Are they relying on a nutrition supplement to make sure they're getting enough calories in? That's just like a very foundational basis. Okay, so maybe they do meet that, maybe they don't. So from there, I go through an initial assessment and say, how do you feel about trying new foods? Does that scare you? Does it make you nervous? What are kind of some of your thoughts and feelings, if they can articulate it? Go from there. And then from there, we probe other questions. Okay, so when you try bread, just plain white bread, how does that make you feel? Does that make you feel safe? Now, if I were to toast the bread, how does that make you feel? You get nervous about cutting your gums? Okay, so then that's another that's ARFID. Do all toasted things make you nervous? Yes or no? Do sharp edges on chips make you nervous? How do you feel swallowing? Do you overchew your food? Do you underchew your food? Have you ever choked before? Do you have a fear of vomiting, right? It's all these other things that are kind of probing questions to them that a lot of times will lead down to ARFID. Oh yeah, I remember when I choked when I was 7, and so I get really, really scared if I don't overchew my food, which can then lead to exhaustion during a meal, which leads to under eating a lot of times. So it's all these different factors. But so when a client comes in, I start with that. It's kind of those basic DSM-5 questions, but then from there, I just ask about how they eat, and then kind of ask other probing questions about the fear of eating. Are you scared if your gums get cut? Are you scared of choking, gagging, all those things?
Are there, outside of those things, so gums getting cut, choking, gagging, that kind of thing, are there other consistent fears that you notice most of the time that someone might have?
Yeah, great question. Yes. So a lot of times, I'll use yogurt for an example on this one. A lot of times yogurt is accepted because it's one consistency, right? If you just think plain vanilla yogurt, one consistency, it's smooth. The minute you add chunks, no. So like adding like a strawberry yogurt, not always accepted because there's chunks of strawberry, or if you want to add granola. When you add 2 different consistencies, that becomes a no-no, and that becomes really hard. One of the things that has really come up a lot recently is that we've kind of broke through with a lot of clients is them they search for the imperfection in their mouth with their tongue. And this tends to be kind of your older population of ARFID, so later teens into adults. Because they've been doing it for so long, they're searching for the imperfection so they can spit it out if they don't want to, or they know this is the part that I didn't like, rather than how you and I chew. We kind of keep everything together and then we swallow as a bolus, that whole food item together. Whereas a lot of times in ARFID, it starts to get separate. So they'll separate the yogurt from the granola, or the skin of the blueberry from the inside of the blueberry. And so that can be tricky to kind of have to help them relearn how to chew, which tend to want to have a speech therapist kind of get involved in there too, just to kind of help them oromotorily as well.
Yeah. And so that, and I know you do this a lot, is a really great time to actually have a snack or a meal with a client to see. So when you're doing that very targeted exposure therapy, what does that look like? And kind of, what things are you bringing up? What are you working on in those sessions?
Yeah. So a lot of times I really do this in the first or second session is I have this huge food list, and we go in together. Hey, what foods are accepted? What foods do you just kind of feel neutral about? They're not super scary, but you don't love them. And then we have the absolutely avoided foods, or foods that terrify you to try. So we kind of put everything in those categories, and they have complete control over that. That's no one's influencing it, it's just how they feel about it. So then from there, we usually start with the foods that they like and pair it with a neutral food. So I like to start with food exposures right away and they're in complete control and complete in the driver's seat. They get to manage everything right at the beginning because they need to feel like they can trust this process. So let's say they love buttered noodles, but cheese kind of gives them a weird consistency on their tongue, but they like cheese when it's melted, but not all the time. It's kind of one of those neutral foods for them. So we start with buttered noodles the first session. We talk about how that feels. And then maybe the next time I say, okay, we're going to add just some mozzarella cheese on top of one noodle. How does that feel? Is that scary? What does it smell like? What does it feel? We'd start with those senses first, outside of the mouth. And then if they feel like they can, then we actually try that food together. We have it sit on their tongue if they can. They're allowed to spit it out. And then we talk about what it felt like, what it tasted like. Did that bring up anxiety, or did it actually, after you put it on your mouth, did it decrease your anxiety? Like, oh, this actually made this taste better, and kind of work through those stages. So that is kind of, in a way, food mapping. Kind of, if they have a goal of like, I really want to like all pasta. Well, we start with where they're at, and then we work our way there, however fast or slow they're willing to go. And then we may do buttered noodles and mozzarella cheese for like 6 sessions. Okay, that's totally cool. But however many times they need to do it to not feel anxious about it. One of the things I always tell my clients too, it can take up to 40 times plus for you to actually decide if you like a food or not, especially with ARFID. And it's not just necessarily eating one noodle at a time, right? But it's 40 different exposures. So maybe you're trying different types of noodles with butter and cheeses and things like that in order for you actually to make a decision at whether you like this or not, which that's a lot of times to try something.
That is a lot of times. And especially if time 1 feels really hard and overwhelming, to come back for time 2, hopefully it feels a little bit better than time 1, but it still kind of doesn't feel great to keep that going. I mean, that is exhausting physically and mentally. So it does. I mean, your approach really is one of empathy and patience, which I think is what makes you really great at working with this population, because you have to have those things in order to get through. If we've got to do something 40 times, there has to be empathy and patience involved.
That is typically where I see some parents get frustrated. They're like, we've been at this for a really long time. And so I always just tell my parents, this is a process. Every eating disorder is different. Some foods still go super fast through, other foods still go super slow. And that's okay. It just kind of just trusting the process. And we want them to be able to eat a wide variety of foods because, as we all know, we're all, dietitians here. We know that's important for our gut health, our mental health, our overall health, all the things, right? Having a wide variety, because it helps us to go out to eat with friends and enjoy food to the fullest and all the things. But it can be a long process and it can be a quick process. It really it's very client dependent.
Yeah, it depends on, what they want for themselves. And I think that's one thing. And I am guilty of this, of like, what I want for you is to be able to go out and eat all foods in any situation and not have anxiety. And, that's a bit utopian, I think. But I think a lot of it is self-driven by the client of like, where do they want to get to have the quality of life that they want to have? And I feel like that varies for everybody.
Yes, very much so. I mean this in a nice way. It's a very cool disorder because it is so driven by just so many different things. And like the want behind getting better is so different for everybody. It's just very fascinating to work with.
Yeah,
these clients.
Absolutely. If we're thinking about having different exposures, when would an RD or a provider know when to like abort mission in a session, right? Like when is it too far? And if the client can't articulate that, how would you know?
Well, typically tears would be shed if the anxiety level is too high. So that is like kind of very nonverbal response of like, I can't do this. Before you start any food exposure, I always ask the anxiety level. You need to ask to make sure that they're feeling okay. Christy, you sent us a while back the CEDS scale, so I tend to use that a lot with my clients of just kind of regulating, where are you at with your anxiety? Are we at a 7? Are we at a 6? Typically, if they're more than a 5 or 6, depending on the client and how well they can cope with their anxiety, we will do the food exposure. Some clients can't go above a 4 because then it'll spiral to a 10, or, they'll completely break down. But I always ask their anxiety level and if they feel like they can do this without having anxiety or panic attack. If the answer is yes, I can do this, I can talk this through with you, I feel supported, okay, we're going to do it. If it's, I feel like if I do this, I may need some skills to help kind of talk me down as the food's sitting in my mouth. And then other times it's like, can I just touch this and smell this today? I really don't think that I can put this in my mouth right now, because there may be other external factors that are going on too. Maybe there's a loud dump truck outside, right? Or other life things that are going on. They just feel like this is going to put them over the edge, and that's okay. Because just smelling it and touching it is helping them get used to the texture for their tongue and their, chewing and all that stuff. So I really never go past a 7. 7 is my absolute hard stop, but then very much client dependent. They're under that. And if a client is getting emotional, very quiet, I feel like starting to disassociate a bit, I typically won't do the food exposure. We'll just kind of talk about it. Talk about why this is causing this reaction to happen.
Right. And so you mentioned the CEDS scale. So CEDS is an acronym for subjective units of distress. And so that is a gauge of measuring overall anxiety, like you were talking about. Can you tell us a little bit about the numbers in the CEDS scale, and like when you're referencing a 4 or a 7, what that means?
Mm-hmm. Yes. I'm not going to lie to you. I need to pull up all the things, but typically a 4 is like, I can deal with it. It's causing me a little bit of anxiety, but it's not going to put me into a panic. It's more just like I can feel maybe my heartbeat increasing slightly. Maybe no perspiration or anything, but just like a little bit more anxious. Maybe blood pressure is raising up a little bit. You get to more 5 and 6. I try to put like tactical things with this. So I'm like sweating. That's one of it, when you get to like a 5 or 6, maybe I'm trying to think of like a specific client example. Like I know one of my clients starts to like bounce her leg just like as she starts to get nervous. Not as like a caloric burn thing with other eating disorders, but that's like her stemming. That's her way to help deal with some of the anxiety, like kind of releases some of that anxiety and tension for her. You may notice a little more fidgeting, potentially some sweating, depending on the client, their nervous level. And then a 7 is where they're starting to feel more like that true panic set in, but they're not completely shutting down from it, because that's more of like a 10. I'm not gonna be okay. Like this is gonna cripple me for the rest of the day kind of thing. A 7 is more like I may start to cry, I may start to feel really anxious, maybe start to get a little irritable kind of thing. Am I explaining this right?
No, that completely is perfect. Yes.
Okay. I was like, do I need to give more examples of this? But yes, no. So that's typically how I break.
Yeah. So anything 7 or above, we're probably not going to do the actual exposure that day, but 6 or below, we're going to try to work through some of it. Okay.
Yep.
So what are as we have like our last few minutes, what are your top 3 tips for treating ARFID?
Yes. So depending on the age level, I'm a huge believer in like including the family. So if it's under 18, or even over 18, depending on college age, like including the family, because family support is really important here, because there is so much anxiety around mealtime and trying new foods that having family support is crucial. So involving families or partners, if you're, an adult living on your own, just involving your support system is like number 1. Got to make sure we have a great support system. The second thing is, like I had said, that food list to help base your exposures from. Food exposures are going to be your best friend in this, because that is the only way to help decrease it from quote unquote triggering them every single time they see it, smell it, try to taste it. So food exposures are my bread and butter. And like I said, we do it at the pace of the client, which brings me to point 3. Do it at the pace of your client. You cannot force this on them. It cannot be cookie cutter, as with any eating disorder is not cookie cutter, or anything with health in general. So you have to really base your treatment approach on what that client is needing when. Just because it worked for one client doesn't mean it's going to work for another, but really meeting them where they're at, meeting them at the pace that they are at. And as a provider, you don't need to be working harder than them. You just need to meet them where they're at and give little nudges when needed. But so those are like my top 3.
That's awesome. So what would you say to a provider that maybe is feeling, it could be somebody that's trained in eating disorders or wants to learn more about eating disorders, that's feeling that sort of like anxiety of like, oh, this one is a little different. It's one of the newer diagnoses. Like, what would you say to that person that's wanting to build their knowledge and confidence, I guess, really in treatment?
Yeah. I feel like this is definitely like a follow your gut type of thing too. But there's some really good resources. I like a book that I found on Amazon. Let me grab it. It's ARFID, but it's actually it's a guide for parents and carriers, so just providers. And I think it just kind of gives a good background of what is ARFID, what people can do to support ARFID. So, and it's a quick book. It's not super long, and it has like a few diagrams and stuff in it just to kind of help you understand like why their brain is thinking the way that it is, why they may be tasting things differently than you are. I don't know. Could we link it in the show notes or something?
Yeah. And what's the name of it again?
It's just ARFID, Avoidant.
Oh, literally just ARFID. Okay.
Yeah. And it's a guide for parents and caregivers or clinicians.
Yeah.
But yeah, we can link it. And it's on Amazon. So
perfect.
Should be a quick delivery. So that's one. But then also reaching out to other providers. Like one of the providers in Charlotte and I usually work pretty close together with we share just a lot of ARFID clients or their practice. And I do just because we know how each other work. We've talked a lot about ARFID. I've learned from them. They've learned from me. And I've reached out to a lot of people to ask about it. I've listened to a lot of podcasts just about childhood nutrition, especially to kind of get a better understanding of like what's quote unquote normal for a child, toddler, kid to go through eating wise, and maybe what's a little abnormal. So really just allowing yourself time to learn and grow, as with any eating disorder. You can't learn everything overnight, but the more exposure you have, the more clients you take on with it, the more you'll learn about it too.
Yeah, I really like that, like kind of foundational, really thoroughly educate yourself on what, like you said, normal, in quotes, normal childhood feeding looks like. So then you can differentiate between like, okay, this is starting to feel like a little bit not that. And it gives you a really good basis of comparison. All right, cool. Excellent tips. So thank you so much for being on today. I feel like this was really informative. I learned a lot from you. So it's been really great. We appreciate your time and your wisdom.
Thank you so much for having me. I loved it.
All right, you're welcome. Thank you for joining me today on Nutrition Unfiltered. If you enjoyed today's episode, please share with others that might enjoy it as well. You can follow me on Instagram at eatingdisorder.dietitian. Thanks for getting sassy with me.